very much. And can everybody hear me okay?
Yes.
Thank you. So first of all, I'd like to thank Dr. Cui for having me here. It's a great honor here. And also a special thank to Dr. Mark Lee, who actually introduced me to the association when I first moved to this area. So today, actually when Dr. Cui asked me to give a presentation, he first asked me to talk about spinal stenosis. I was a little bit overly ambitious. I said, well, I'm just talking about surgical spinal disease. And after that, I realized I only have 20 minutes to talk. It's impossible to cover everything. But I still like to take the opportunity to go over the topics that a neurosurgeon like me that we're dealing with, and also a brief introduction to what's the latest technology in terms of treating those diseases. So I have nothing to disclose in terms of conflict of interest. Some of the pictures I use here is actually copyrighted to other authors. So the scope of neurosurgeons practice actually varies in different countries. But in the United States, a neurosurgeon like me will practice on both the cranial and the spinal disease. This is basically incomplete and a brief summary of what we treated, which I treat cranial disease such as brain tumor, we treat tumor encephalitis, and so forth. But when it comes to spine, which is actually a major part of neurosurgery practice, with the majority we're dealing with the spine degeneration, which will be the focus of my talk today. Again, we kind of focus on spinal stenosis, Dr. Cui suggested, but there's also some other degenerations that we deal with, and it could be tumor and trauma. Now, what do we use as a surgeon? So typically, the surgeon talks to the patient saying we're talking about traditional so-called open surgery. The spine, as mentioned before, it supports our body's mechanics, support our weight is in the back of our body. But when it comes to spine surgery, you can go from the front, you can go from behind, or you can go from both in front, from the back. And that's all the traditional open surgery. But these days, what caught people's attention, both the physicians and general public alike, is the minimally invasive surgery, which I think is becoming not just a trend, it's becoming standard for most of the spine surgeries. And also the newer technologies such as intraoperative navigation that I'll touch upon at the end of this presentation. So here's a kind of brief anatomy of our spine. Our spine actually varies slightly among individuals, but we pretty much always have 7 cervical vertebrae, that's the spine and the neck. We also have 12 thoracic vertebrae. This actually varies a little bit among people. And finally, we have 5 lumbar spine in the lower back. The reason I highlight cervical and the lumbar in this presentation is that these are the area, again, the neck and the lower back areas that you see the most degeneration because how we move. The thoracic spine is relatively spared by the front degeneration because the rib secure the spine to the front and therefore they're not moving as much. So why would degeneration happen? Because we use it a lot. It's a mechanical stress and it's what's called wear and tear. We also move it a lot. And the moving part wears out just like the car engine or transmission. Eventually, they will have some problem. So what will happen when the spine degenerates? Honestly, a lot of people actually don't feel it. That's why I listed feel nothing first. A lot of times actually don't feel anything, which is perfectly fine. You don't need to deal with it if you're not feeling any problem. A person can also feel pain in leg or arm, numbness, weakness, or something called neurogenic claudication, which I'll touch upon later as well. And they may experience problems with their gait. They may feel unsteady when they walk. In some severe situation, the control of bottom bladder can be affected because the nerve going down there is also affected by spine problem. Now the last one, I ironically put it the last one, neck or back pain, ironically because this is actually a very, very common problem. I listed at the bottom and also kind of de-highlighted for a reason, because those are actually more tricky than just a spine issue per se. So diagnosis, taking history from patients is extremely important. You have to know their characteristic of pain, where the pain is, how the pain is induced, and what other problems they may have, numbness, weakness, for example. Physical examination is when the physician performs the exam on them to see their true weakness and numbness and check their reflex and so forth. Imaging studies are basically the major and indispensable part of the diagnosis these days, especially MRI, which gives us a lot of information. X-ray still provides some information, especially when it comes to so-called dynamic view. Basically, you ask the patient to move it, stand up, and take X-ray. That'll give you extra and valuable information. CAT scan, CT scan can be helpful when the MRI cannot be done, or in some situations, CAT is necessary. The other tests, for example, the electrical test, EMG, the electromyogram, or nerve conduction velocity study, that can help the physician and patient figure out what's going on with their spine. Now, here's the problem, though. Here, I mean, except for some very young attendants, everybody's MRI of the cervical and lumbar spine is going to be abnormal. That's how common it is. Nobody, even if you have no pain right now, no numbness, you take an MRI of your neck and lumbar spine, you're gonna find a problem. Nobody's completely normal. On the other hand, though, the reason I put the neck and back pain the last, the items is like that neck and back is also extremely common. 80% of adults is estimated to be at least hit once by the neck or back pain once in their lifetime. But these two don't necessarily correlate that well, meaning if you see problem in MRI, very often the patient comes to the office very anxious because they read an MRI report saying they have 10 different problems. They say, do I need to fix all of them? In fact, most of the time that doesn't necessarily correlate or point to the problem. And also, if your friends or family have got back surgery before, or neck surgery before, the back or neck surgery has a kind of mixed reputations also because sometimes surgeons or even patients are jumping the gun too quickly, so to speak, that they try to fix, quote unquote, fix the problem of surgery with some invasive way. It turned out that actually got things worse because both conditions, that is the pain the patient feels with the neck and back, extremely common, but also the problem we found in MRI is also extremely common. It covers such a huge population, but it's actually not a perfect correlation. So we got to be, that's a challenge as a clinician dealing with spine problems. We got to be very careful about how we approach these. One of the complexity though is, we're all talking about spine to show a picture of bone, but our back is not just the bone. Our back is full of muscles. And these areas can cause pain too. By trying to fix the bone problem while the spine problem doesn't necessarily fix the muscle problem. And in fact, all the surgery creates some trauma to the muscle and therefore can aggravate the pain. Anyway, so I'm going to go back to the focus because time limit that spinal stenosis that what Dr. Trey asked me to talk about. So spinal stenosis basically is a medical jargon, meaning some part of the spine that's narrowed. And the picture shows spine anatomy again to see what's narrow. But they actually, because there's 3 different regions of spine that can have stenosis, so it can be cervical, lumbar, or thoracic. And thoracic is less common because it's not subject to degeneration as much. In each region, there are also 2 types of spinal stenosis, and although colloquially it might be hard to distinguish, one is spinal canal stenosis, which is actually for physicians when we talk about stenosis, we meant this type of stenosis, but also another thing, the foraminal stenosis. And to illustrate this point, so this is a lumbar spine example. Do we have a pointer that I can use? Right here. So, I got it. It's kind of weak. I can only use. I can only show on this picture. I can't do on both. So, not like that. So I don't think they see the laser pointer. So this is a cross-section of the lumbar spine. What we meant by spinal canal is actually this space, like a semi-triangular shaped space. That's where the bundle nerve goes through. That's called spinal canal. What a foramen, though, is the little holes on the side of the spine which the individual spinal nerve exited the spinal canal. So the spinal canal stenosis means the canal itself gets narrow, while foraminal stenosis means the hole itself gets narrow. The reason for that happened, though, is this part is a little washed out, but I have a red circle here to point out the joints. Also, the arrow points out a disc, which is the pushing path between the spine. Spine degenerates because the moving parts, which undergoes a lot of wear and tear, degenerate. When it happened, if you went through a kind of counterintuitive, the body try to compensate by growing things. So you get bone spur growing on that, and the ligaments get thicker. Unfortunately, in the case of spine, it encroaches on the passage of the nerve, and therefore causes stenosis and pinches the nerve and causes the issues. Now, this is the actual, so this is an actual example of a patient's MRI of mine. So on this side, on the left side, the cervical spine, again, the snake-like structure in the middle of the spinal cord going through the cervical region. But you can see, I don't know if you can see very well, the spine got pinched here, and in fact, the spinal cord changes color, turning from gray color to white color because it's being squeezed too much. This is a classic example of cervical spinal stenosis.
Down here is a lumbar spine stenosis. It's actually one of Dr. Lee's patients. Again, normally you should get this triangle. I'm showing you at what level the patient has no stenosis. Normally you should see this white triangle where the bundle of spinal nerve goes through in the canal. While the level of the patient has stenosis, if you obliterate this white space, and now it got it totally dark down because the nerve is being pinched big time. So these are the MRI example of actual patients that's showing spinal stenosis. Oops. We're way down, sorry. So the classic symptom of stenosis for lumbar is neurogenic claudication. So these patients, they may not tell you they have any problem when they're resting. They may be feeling fine, sitting fine, or even standing up, they're fine. But they'll tell you that when they walk, they used to be able to walk, let's say, a half a mile, 1 mile, now they could only walk for about a block, or even they couldn't even finish a round in the grocery store. And what they would tell you is that they could have pain, numbness, or weakness in the legs, and that would make them stop. Once they stop, take a break for a few minutes or half an hour, and feel good again, and get up, and after another 1 block, the symptom came back again. And that's called neurogenic claudication, basically intermittent being hit by this problems leg, they couldn't walk. In more severe cases, they start having more persistent pain, numbness down to the leg. In a very severe case, they lost control of bottom bladder, and there's a term for that, it's called Canal syndrome. Canal is actually the medical term for the bundle of nerve going through the spinal canal that's being pinched in a big way. Now, the key issue is that most of them do have some back pain, but they'll tell you that's not a major problem. Their main problem is actually with the leg, and that's a very classic thing for lumbar stenosis. For the cervical stenosis, it's a little bit different. One of the key features that they'll tell you they can walk very well. They may not actually feel weak, they just feel unsteady. They may not actually have pain either, they just feel very unsteady. In fact, the MRI I just showed you on the cervical stenosis patient, that patient barely has any pain in the neck, but she just couldn't walk, very unsteady. Again, similarly, as the lumbar spine affecting the leg, the cervical spine will affect the arm, they will have pain. Now, the same thing in the arm. And the symptom in the leg may be a little bit less obvious. The leg can still kick you very strong, but they just don't work very well. In very severe cases, the control of bottom bladder can be compromised. Again, same thing as a lumbar issue. They may have neck pain, but a lot of times that's not their main problem. So treatment, as a surgeon, I become a surgeon because I love doing surgery, but I always tell the patient, if possible, try other things first. So you can try physical therapy, you can try medicine, you can pain, you can try injections by pain specialists that can help. Again, the primary care doctor, neurosurgeon, is actually the best person to talk to about what can potentially be done. Now, if everything else fails, then surgery can be an option. For a neurosurgeon, before we do any surgery, number one thing is we have to make sure we have the target that we can do something we call decompression. Take pressure off the nerve. That's the top priority. And we don't, it is a neurosurgeon, I don't believe that you should put in screws and rods to secure the spine without doing decompression. Any patient going through surgery must have a reason to do a decompression. The standard for treating spinal stenosis is using something called laminectomy, removing part of the bone. I decided to procedure down there just because all those things are what a neurosurgeon can employ when they try to treat a spine problem. Like a decompression, in my opinion, is the key. Now, this is what happened in the laminectomy in the traditional way, again, open surgery way. So what happened again, I don't think I see the point again. The problem is the spinal canal is being squeezed by the ligaments, by the joints and whatnot. So the surgeons will remove part of the bone called lamina, which cover, basically form the root of the canal and take the pressure off. And this is the kind of cartoon like that. Now, I'm including this actually one of my actual patients. I rarely do this open way anyway, but this is a trauma situation, so it's different. So to show you is that this is CAT scan. Again, before the surgery, the patient's an intact bone there. Now after the surgery, take the pressure off, the bone is off. That's a typical laminectomy. So advantage, if the patient has a classic lumbar stenosis claudication symptoms, it's the most effective way to treat them is a laminectomy. They fare very well, they recover fine, and they don't have any other issue. Disadvantage though, if you do an opening, it's actually a lot of tissue dissection. This diagram down there in the right lower corner shows how much muscle we actually have to open up to get down there, even for just a one level surgery. And the thing is also, we don't always get a very clean bill on those patients. They may not just have one level lumbar stenosis, they may have 2 or 3 or even 4. The more level you do, the incision gets longer and longer, the wound gets bigger and bigger. They have more problems, pain, and potentially more complications from that. So now the buzzword everywhere is about minimally invasive surgery. So concept is that you minimize the opening. The priority though, you still have to be able to achieve what you need to do without, while achieving less tissue damage. But it also has a kind of unique advantages that you can do things that the open surgery cannot do. So this is the difference. Again, the previous cartoon, open surgery, open big time. But in the minimally invasive surgery, when it comes to spine, we use a tube, almost like a telescope. We put it into where you need to operate, make a small opening. And you use a microscope, some surgery use the endoscope to get down there and do treatment. So this is an incision comparison. Open surgery on the left, that's actually very classic, especially for bigger patients with more fat, more soft tissue. The incision is about that long for even just 1 or 2 levels. On the right-hand side, so that's a typical lumbar spine minimally invasive surgery incision, just about the size of a dime. And you can actually treat that even 2 or 3 level decompression with just the same size incision. Similar things, I'm just showing a few examples. We don't have that much time, but you can do it even fusion surgery with those. Again, this maybe a little bit gory for some of the audience here, but on the left is traditional multi-level fusion surgery at the ginormous opening. Have put on the screws on the right-hand side, like put small tubes down there. The overall tissue trauma is a lot better. They fare better too. So advantage, the real demonstrated advantage is the post-op pain is less. But what's not being talked about too much is actually infection rate is much less, and some other complication rate is also much less or easier to control. The disadvantage though, there's still some situations, still a learning curve, it's still kind of evolving thing that there's some situations we still can't use that. Now I just pull on this because so many patients ask me about laser spine institute. Again, I don't have time to dig into that, but bottom line, laser doesn't work in that way. If you're interested, we can talk about laser. Now the last few slides I will talk about some new things just recently acquired in the hospital. It's becoming a trend. This was intraop navigation. So again, traditionally, if we get to more complicated spine surgery, if they put in screws and whatnot, 10% of the time those screws are suboptimal. They can be off, they can cause trouble, patient may need a reoperation. However, intraop navigation, and actually the equipment I'm showing you is the one we have at suburban hospitals I work. It allows you to put a screw almost 100% accurate. You can actually verify it before you finish the surgery, so the patient doesn't even come back to surgery after the casket and show the screw is off. Save a lot of time, absolutely accurate, so you have less risk of damaging the nerve. And in most of the recent neurosurgical gathering, this is basically becoming almost like a standard now, especially for complex cases. And also facilitate some other things, for example, robotic surgeries I don't have time to talk about, but robotic surgery is also gaining the momentum, and eventually, when it comes to spine surgery, part of spine surgery, it will become the standard. So again, I have to take the opportunity to thank everyone here to listen to me, and this is just pictures of the hospital I work with, suburban hospital in Bethesda, Maryland. I spend most time there. Being a Johns Hopkins faculty, also work at Johns Hopkins Hospital for some patients they prefer to do the surgery at Hopkins, but both hospitals are excellent and can provide the care we need. Thank you very much.
Last question.
Yes.
Dr. Lee, thank you very much for taking care of my patient.
Oh, thank you.
And what I always face a dilemma. What's the risk factor for patient with spinal stenosis? And how can we prevent that? Like what we know the best outcome for spinal stenosis surgery. And the surgery always elderly patient, pacemaker, aging pain, anticoagulant, cannot do MRI, cannot do anything. My dilemma is how to prevent that. And I go so far as I review some article on Tai Chi can prevent the TJD progression. But no way to predict which patient may be for spinal stenosis, how to prevent a patient become spinal stenosis. That's why you talk about symptoms, talk about that. That means we will not have patients. Because most spinal stenosis, every patient, a lot of complications from unmet problems.